Assalamualaikum and good day everyone. So my lecture today is on approach to breast cancer. So my lecture is meant for my medical officers, master students of surgery, and revision for general surgeons. So this is my flow of lecture today: introduction, risk factor, screening, referral, and the main bulk is the assessment and diagnosis and the treatment of breast cancer. So we go a bit on introduction of breast cancer in Malaysia. So in our latest cancer registry, 2012 to 2016, so we notice we have 19% of all new cancer cases regardless of gender. So from this, we have about 34% new cases from the overall cancer among women, which is an increase about 2% from previous data. So we also noticed that from our data, the incidence of breast cancer in Malaysia started to increase at the age of 25 years old and peak at the age of 60 to 64 years old. So the incidence is highest among Chinese, then Indians, and then followed by Malays. So at diagnosis, patient will come to us at stage 1 and stage 2, about 52%, and another 48% will come at stage 3 and 4. This is an increase from 43% previously. So why is this? I think for stage 1 and stage 2, now we have a better screening program in Malaysia, early referral to breast clinic, hence we detect more patient at stage 1 and stage 2. Okay. At the same time, because of early referral, more access to screening, more access to mammogram, ultrasound, and assessment, we also detect more patients at stage 3 and 4, especially from the rural areas. Okay. So overall, 5-year relative survival is about 66.8%. So patient at stage 1, 80% of them have relative survival up to 10 years, 80%. Stage 2, 80% relative survival up to 5 years. In stage 3 and 4, they have lower relative survival. There is a better relative survival among the Chinese, then Indians, and then Malays. Okay. Risk factor. So we divide risk factor for breast cancer into two, non-modifiable and modifiable. So in non-modifiable is the age. The older the patient, the higher the risk of getting breast cancer. Gender, female gender, higher risk of getting breast cancer. Family history, especially the one with gene mutation, BRCA1, BRCA2, LB2, ATM, CHEK2. Okay, and then reproductive factors, early menarche, late menopausal. So this patient will have a longer exposure to estrogen, hence higher risk of getting breast cancer. Then any history of neoplastic breast disease, and lastly, breast density. So the higher the breast density, the higher the risk of getting breast cancer. So all these are non-modifiable risk factors. So in the modifiable risk factors, we have reproductive factors too, nulliparity, lack of breastfeeding, old age at first life childbirth. So all these are modifiable. Why? Because patient can choose to become nulliparous, single, or married. So they also can choose whether to give breastfeeding or not to give breastfeeding. Okay. They also can choose to have the first life childbirth at an earlier age or at later age. Okay. So this is a modifiable. Then we have hormonal factors. Patient on oral contraceptive pills, patient on hormone replacement therapy, okay, they have a small risk of getting breast cancer. How about lifestyle? So patients who are overweight, obese, especially in a postmenopausal woman, they have a higher risk of getting breast cancer. Same goes to patient with low MET, the one with lack doing exercises. And also patient taking alcohol. Okay. And lastly, radiation exposure, especially patients who had irradiation at a young age to the chest, for example, in the treatment of Hodgkin lymphoma. So they have higher chance of getting breast cancer. So these are the modifiable risk factors. So both non-modifiable and modifiable risk factors are important for us to identify when patients come to see us. And we have to identify all of these factors during our first consultation with the patient. Okay, all right. So next, screening. Okay, so when we talk about screening, it means we screen a population of patients with no symptom, no sign, but have the risk of developing breast cancer. They also don't have any family history. So this is screening. So patient will come with no symptom, no sign. So we screen them. Okay. So to make it easier, so we divide them into general population and the one with the high risk individual. So who are the patient in the general population? So these patients are the ones who has no personal history of breast cancer and also no family history of breast cancer. So all of them will go under general population. Okay, and who are the ones with high risk individual? So the ones with BRCA gene mutation, okay, or patient with first degree relatives of BRCA carrier, okay, history of chest irradiation at young age, okay, then personal history of breast cancer, and strong family history of breast cancer or ovarian cancer. So these are patients with a high risk individual. Okay, all right. So how do we screen them? So for general population, the recommendation of screening is for women aged 50 to 74 years old. So we recommend for them to do mammogram every 2 years. Yeah, that is for general population. Okay, for high risk individual, we divide into two groups. One is the one with no genetic variant, okay, and then the other group is with genetic variant. For example, BRCA1, BRCA2. So in high risk individual with no genetic variant, so all women aged 40 to 59 years old, so we suggest to do annual mammogram. Women 60 years and above, we suggest to do mammogram every 2 years. Okay, and any woman less than 40 years old, we can consider to do mammogram. Okay, how about high risk individual with genetic variant? So all women aged 40 to 69 now, we suggest to do annual mammogram for screening. Then women more than 70 years old, we suggest do mammogram every 2 years. Okay. Also, women aged 30 to 49, we can also suggest to do MRI annually if indicated. Okay. This is the screening recommendation in our CPG guidelines. Okay. All right. So referral. Next is referral. Okay. So we suggest for early referral, which means we refer early to breast clinic or surgical clinic within 2 weeks. Who we should refer? All women aged more than 35 years old with symptoms and signs. So what are the signs? We make it easier. Only three, which are palpable breast mass, breast pain, and nipple discharge. These are the women with symptom and sign more than 35 years old. We should refer early, within 2 weeks. Or high risk groups with symptom and sign, the one that we spoke just now, high risk individual, the one with BRCA mutation, family history of BRCA carrier, okay, personal history of breast cancer, strong family history of breast cancer or ovarian cancer, and history of irradiation at young age. Those are high risk group with symptoms and signs. And also patient at any age with clinical symptom and signs of malignancy. So what are the signs of malignancy? So the breast lump is hard, fixed, then there is asymmetry, thickening, and nodularity, and there's blood stained nipple discharge, there is axillary mass. There's also if patient went to do a mammogram or ultrasound, there we noted the images noted or detected suspicious lesions, or there is skin changes, body rash, erythema, nipple excoriation, scaling or eczema, skin ulceration, and satellite nodules. So these are the patients which we need to refer early to the breast clinic or surgical clinic within 2 weeks. Okay, this is on referral. Okay, so assessment and diagnosis. So when we talk about breast cancer assessment, the gold standard is triple assessment. Okay, which consists of clinical assessment, imaging assessment, and pathological assessment. So in the clinical history, we should take a good thorough history, and then we do a complete clinical breast examination. Okay, imaging. Okay, all patient age less than 35 years old, we will do an ultrasound breast, or more than 35 years old, we can do mammography with complementary ultrasound to image the breast lesion, breast lump. Okay, there's another option now. We have digital breast tomosynthesis (DBT). This is a 3D mammogram. Okay, as compared the normal mammogram is a 2D mammogram. So DBT is a 3D mammogram. It can detect can give better images and can detect better the lesion. Okay, then we also have option of doing MRI in certain patient. So we will see it later, the indication. Which patient we should do MRI. Okay. So lastly, pathological assessment. So most of the patient we will take core needle biopsy. If the biopsy is not available, we can take a fine needle aspiration cytology. Okay. So we go one by one. So clinical history. What are the important history that we should ask in our first consultation with the patient? So to make it easier, so we divide in our history of presenting complaint. Number one is all about the breast. So we ask about the breast lump, any ulceration, any bleeding, any infection, any skin changes. Okay. Then we should ask about the nipple areola complex, any nipple inversion, any nipple discharge. Okay. And then also don't forget the next one is axilla. If there is any axillary lump or mass noted. So breast, nipple, axilla. Okay. Then we should ask about constitutional symptoms, which is if there is, maybe it's suggestive of malignancy, which are loss of appetite, loss of weight, and fever. Okay. Next, you should ask about metastatic symptom. Okay. If let's say the lump is a breast cancer, patient might has metastasis to solid organ. So if patient has brain metastasis, so the symptoms will be dizziness, headache, blurring of vision, double vision. Okay. Next, let's say lung metastasis, so patient can have shortness of breath, pleuritic chest pain, hemoptysis. How about liver metastasis? Patient can present with jaundice, abdominal distension, abdominal mass, lower limb edema. Okay. If bone metastasis, patient can have bony pain, joint pain, or pathological fractures. Okay. Alright. So next important thing you need to ask in the clinical history is the risk factors. Age of menarche, age of menopausal. Is the patient nulliparous, multiparous? How many children the patient has? What are the age of the patient, of the first live childbirth? Any history of breastfeeding? Is the patient on OCP or on HRT? Any previous history of neoplastic breast disease or breast cancer? Any family history of breast cancer? Is the patient taking alcohol? Is the patient obese? Lack of exercise? Is there any previous breast surgery? Okay. And lastly, you should also ask about the fitness of the patient for operation. Is it patient is fit for op or not? That one you should explore during your clinical history taking. Okay. So next is a complete clinical breast examination. So this is a video from Prof. Aisha from Department of Surgery, University of Malaya. I think this video is one of the best video on clinical breast examination. So we'll see, and then you compare yourself with your examination in the breast clinic or surgical clinic. Is it similar or is it better? Okay, we'll see.
Examination requires certain protocols to be adhered to. Namely, number one, we should actually respect the privacy of the patient, ensuring that the room is comfortable as well as private. Number two, we should always have a chaperone with us to be able to perform this examination, which is very sensitive in nature. Now, I would like to introduce myself and take consent from the patient before performing the breast examination. Assalamualaikum Kak.
Salam.
Saya akan memeriksa payudara puan, ya. Tapi kita perlu tanggalkan baju hingga ke paras pinggang. Ya, boleh?
Ya, boleh.
Okey, terima kasih.
Sama.
On inspection, the patient is a middle-aged lady sitting fairly comfortable on the bed, and she seems to be tachypnic. On examination, you could see there is a dressing applied to the left breast, and I will ask my nurse to remove the dressing. First of all, we were going to start with inspection. On inspection, there is an obvious mass located in the left breast, involving mainly the upper part of the breast, extending from the medial to the lateral aspect of the upper quadrant of the left breast. There is an obvious ulcer measuring about 4 centimeters and also 5 centimeters by 3 centimeters located over this fungating mass. There appears to be 2 satellite nodules, which is also ulcerated within the left breast. There is nipple retraction as well as peau d'orange seen in the left breast. We are also going to inspect the supraclavicular area, where we can see a left supraclavicular swelling occupying most of the left supraclavicular fossa. There is fullness in the left infraclavicular region too. We will confirm this later with palpation of the breast. Puan, boleh tak naikkan tangan puan? On inspection of the axilla, there appears to be an enlarged mass within the left axilla. There don't seem to be any tethering of the skin of the right breast. Puan, boleh letak di pinggang? There's still no changes seen in the right breast when she puts her hand on the waist. Boleh tak akak cekak pinggang? Again, with contracting the pectoralis muscle, there doesn't seem to be any change in the right side as well as the left side. Terima kasih Kak ya. Do not forget to inspect the upper limbs. Puan, boleh keluarkan tangan? There appears to be left-sided lymphedema extending from the fingers right up to the upper arm. Do not forget to inspect the back for any scars as well as the inframammary folds for any scars or ulcers. In addition to the 2 satellite nodules, there appears to be inflammatory changes around the skin of the upper chest, involving almost extending to the other breast as well as extending into the neck. Actually, this patient also has a hemangioma of the skin, which she has had since young. However, there are multiple nodules seen on the neck, which is consistent with satellite nodules. Now we are about to palpate the breast. We will start with the normal breast first. When we position the patient...
So why we always start examining the normal breast first? Okay, because each lady, each patient who came to our clinic, they have different breast density. So we want to know what is normal to the patient. So that's why we always palpate the normal breast first. So we know what is normal to the patient. Then we will examine the pathological sign. Okay.
It's best to extend the arm in a hyperextended abducted manner. We can place a towel beneath the patient's scapula to spread out the breast over the chest wall. When we palpate the breast, it's important to use the pads of the fingers, and usually we use 3 fingers. To palpate the breast, we need to know the dimensions of the breast, which is the medial aspect of the breast which crosses the midline, the inframammary fold extending into the axilla, because there could be an axillary tail of the breast, as well as the infraclavicular margin. So that is the breadth of the examination that need to be performed, superficial as well as deep palpation in a circular motion, like so. So we are going to examine the breast in a strip method. That means covering every single breadth of the breast using the circular palpation method that I mentioned before. So this needs to be repeated for the whole breadth of the breast with a circular motion, and this is to detect lumps as small as 1 centimeter in diameter. So this is done to cover the whole aspect, the whole breadth of the breast. So do not forget the axillary tail. There could be masses also present in the axillary tail. And this needs to be done right to the mid-axillary line, which is the line that goes across here. To examine the area of the nipple, palpation should be done to feel for any masses, because there could be masses behind the nipple. And to demonstrate discharge, we can ask the patient to demonstrate. Puan, boleh tak Puan tekan sedikit untuk keluarkan macam nak keluarkan susu tu? Okey, tak ada tak ada keluar cecair Okey, terima kasih. We can also demonstrate this by slowly palpating and expressing the breast tissues. Be careful not to cause any discomfort and pain to the patient. So in this patient, we do not seem to have any nipple discharge. So examination of this breast shows a locally advanced breast cancer, measuring about 20 by 20 centimeters. It is quite firm in consistency. It is not warm to touch, and it's non-tender. Tak sakit kan Kak? The surface of this mass is lobulated. As mentioned before, there's ulceration of the skin as well as peau d'orange seen on this mass. To examine the mobility, I am going to move the lump in 2 directions. You can see that movement of the lump transversely, it is fixed. However, when I move the lump in a vertical fashion, it is slightly mobile, but it is fairly fixed to the chest wall. Therefore, I will not demonstrate contracting the pectoralis muscle. How we show contraction of the pectoralis muscle is by putting the hands on the hips again, contracting the pectoralis muscle. Akak cekap pinggang ya, tekan ya. Yes, we can check that by feeling the pec major and demonstrating the fixity of the lump again in 2 directions. Again, there is not much change in the mobility of this lump when she contracts her pec muscles. Now we are going to examine the axilla. It is best to examine the axilla while facing the patient, and she is seated at the edge of the bed. To examine the axilla, we need her arm and her muscles to be relaxed. So she needs to put her whole weight of her arm onto our hand. Agak relax ya, lembut je tangan. Okay, and then only her muscles will be relaxed for us to be able to feel deep into the axilla. So we need to feel the anterior group of lymph nodes, the medial group of lymph nodes, the lateral group of lymph nodes, posterior group of lymph nodes, as well as the apical group. The apical group requires that you push into the axilla and pull down to feel for any masses within the axilla. Now we are going to examine the opposite side. So similarly, I will use my left arm to hold on to her left upper limb, and I would want her to be relaxed. Agak lembut ya, relax saja ya. Similarly, I'm going to feel for the anterior group, medial group, lateral group, posterior group, and the apical group. In this patient, she has matted lymph nodes measuring about 4 by 5 centimeters, which is matted, lobulated, and fixed to the chest wall. Now we're going to also examine the other regional lymph nodes, like the infraclavicular lymph nodes, which is located here. As you can see, there is a fullness in this side, and you can actually feel a vague mass in the infraclavicular region compared to this side. So she does have involved infraclavicular nodes on this left side. And now we're going to feel for the supraclavicular lymph nodes. They are matted and very fixed nodes in the left side. We will finish off with the examination of the other cervical lymph nodes, especially the deep jugular chain, okay, and also the other groups like the occipital group and so on. This lady has multiple satellite nodules located in her supraclavicular fossa extending to the left shoulder. To end the examination, we will also need to examine for other systemic spread of the disease. Okay, we will also examine for pleural effusion by percussing the back. So there's dullness of percussion on the left lower zone, which may indicate a pleural effusion. Puan ada sakit tulang belakang tak? Tak ada ya? Okey, saya akan buat begini. Kalau sakit bagi tahu ya. So I am looking for any spinal tenderness on the patient which she doesn't have. To end the examination, I will examine the liver. Akak boleh tarik nafas, buang nafas ya. There is no hepatomegaly seen in this patient. We will also complete the examination by looking for ascites as well as any pelvic masses. In summary, this is a 48-year-old lady with a T4D tumor evidenced by inflammatory changes, skin and chest wall involvement, and 3C or with ipsilateral supraclavicular nodes and M1 evidenced by pleural effusion. The patient has a stage 4 breast cancer, and management is multidisciplinary in nature, and the intent of treatment is palliative with symptom control and disease control.
Okay, so by the end of your clinical breast examination, we can give a clinical staging to the patient. So we can give what are the T staging, the N staging, and the M staging of the patient. Then we can categorize the patient whether the patient is an early breast cancer patient or locally advanced or metastatic breast cancer patient. Then we can proceed with the management of each category of patient. So that's on clinical history and clinical breast examination. Imaging, so mammogram and ultrasound will give reporting based on BRADS. So BRADS, breast imaging reporting and data system. So BRADS, we have category 0 to 6. Okay, if you can see properly here, okay, if the BRADS score is 1 and 2, you can see that the likelihood of cancer is almost nil, 0. Hence, patient came with mammogram or ultrasound BRADS 1 and 2, so we can just do a normal routine screening afterwards. Okay, for BRADS 3, you can see that the likelihood of cancer is up to 2%. Okay, hence we can just continue surveillance, maybe TCA every 6 months or yearly. Then we have a short interval of follow-up. Maybe you can repeat mammogram ultrasound next year, every year. Okay, so if the BRADS score category is 4, 5, 6, this is have higher chance of likelihood of cancer. Hence, we have to arrange for the tissue biopsy. So 4, 5, 6, we have to arrange for tissue biopsy. Okay. How about the role of MRI? So we can consider MRI in this type of patient: patient with invasive lobular cancer, patient with lobular carcinoma in situ, suspicion of multicentricity, patient with genetic high risk, occult disease T0, N plus, M plus disease, or Paget's disease with without routine radiological evidence of underlying tumor, patient with breast implants, or patient with foreign bodies. Okay, patient diagnosis of recurrence in previous breast reconstruction, or follow up after new adjuvant therapy, or patient with dense breast. So these are the patient which we can consider to do MRI to assist us in making a diagnosis. Okay, all right. Then our histological assessment is via through cut needle biopsy. So HPE will come back telling us whether the lesion is benign or malignant. So if benign, it can be non-proliferative, it can be proliferative without atypia, it can be atypical hyperplasia. Okay. If malignant, it can be carcinoma in situ, can be invasive. The most common is invasive ductal carcinoma. It can be others. Okay. And now we divide them into subtypes: luminal A, luminal B with HER2 negative, luminal B with HER2 positive, HER2 enriched, and also triple negative subtypes. Okay, and at the same time, the HPE from the through cut needle biopsy will give us the hormone status. It can give us about the estrogen and progesterone receptor status and the HER2 status. Okay, so if the HER2 status came back equivocal 2+, then automatically our pathologist will do further testing in situ hybridization test to see whether the HER2 is positive or not. Okay, positive means 3+, means 3+. Okay, this is on needle biopsy. Okay, so in 2011 we have this St. Gallen classification, which give us the subtypes of breast cancer based on the ER/PR status, HER2 status, and also Ki67. Okay, patient with low Ki67, they have a better prognosis. So that's why luminal A has the best prognosis among the other subtypes. Okay, as compared to HER2 enriched patient with ER/PR negative, but HER2 positive, and also triple negative. Okay, these two has the worst prognosis among the 5 subtypes. Okay, all right. Next is staging. Okay, now we follow the TNM staging according to the AGCC, the 8th edition. So we have the clinical staging, and also we have the pathological staging. And then we will categorize this into the anatomic stage group or prognostic stage group. Okay, so clinical staging and pathological staging for T, you see here, T1 is patient with tumor up to 2 centimeters. 2 centimeters. Okay, T2 is more than 2 to 5 centimeters. T3 is more than 5 centimeters. Okay. T4 we divide into T4A, B, C, and D. So T4A is extension or involvement of chest wall. So what is the definition of chest wall? So chest wall means it involves the ribs and also the intercostal muscles. Okay. So if the tumor just invade or just extend or just extend into the pectoralis major or minor muscle, we don't consider that as chest wall involvement. So chest wall must involve the ribs and also the intercostal muscles. Okay. T4B, so involve the skin. So it must have either one of these three things. Either there is ulceration, that's number one. Number two, whether there is satellite nodules. And number three, there is swelling, peau d'orange. So either one. Okay. Other than these three, we don't consider as skin extension. So this is T4B. T4C is combination of T4A and T4B. So there is extension to the chest wall and also skin involvement. Okay. T4D is inflammatory breast cancer. Most of the time, it looks like an eczema or like an erythematous skin changes of the breast without breast lump. Okay, that is inflammatory breast cancer. T4D. Okay, that is T. And N we divide into clinical N and pathological N. So this clinical N, we divide into N0, N1, and N2, N3. Okay, so N1 means there is a palpable lymph nodes, ipsilateral lymph nodes. Okay, N2 also ipsilateral lymph nodes, axillary lymph nodes. However, the lymph nodes is matted. Okay, it is matted of fixed. That is N2. Okay, N3 means is already involved ipsilateral infraclavicular lymph nodes. Okay, and above, or your supraclavicular or your cervical lymph nodes. Okay, so in clinical, so you must know N1, N2. Ipsilateral, N1 means there is palpable lymph nodes, but it's mobile. N2, there is a ipsilateral lymph nodes, it is fixed or matted. Okay, N3 is other than that, ipsilateral, infraclavicular, and others. Okay, pathological N lymph nodes, meaning after we have done mastectomy and axillary lymph node dissection, so the HPE will come back showing us the numbers of lymph nodes involvement. So divided into N0, no lymph nodes involvement. N1 means lymph nodes involve 1 to 3 lymph nodes. N2, 4 to 9. Okay. N3 is 10 or more. Okay. That's why most of the time when we do axillary lymph node dissection, we will take at least 10 lymph nodes. Why? Because N3 needs at least 10 to categorize into N3. Okay. So this is pathological N. Okay. Metastasis M is easier. M0 means no metastasis. M1 means there is metastasis. Okay. Alright. So from that clinical staging or pathological staging, so we can divide them into this anatomic stage group. So we divide into 3 groups: early breast cancer, okay, which is patient is stage 1, stage 2A and 2B. Then locally advanced breast cancer, patient is stage 3, and also metastatic breast cancer, stage 4. Okay, stage 4. Right. Okay, then we also have the prognostic stage group, which further divided the patient anatomically, the N and the M, and also according to the hormonal status, the ER, PR, and HER2 status. So they will give the prognostication of the patient. Okay. So from all of this, what is our clinical approach? Okay. So this is how we going to do in the clinic. So during the first consultation with the patient in our clinic, we must take a good, thorough history. Then we must do a complete clinical breast examination. So by the end of our clinical history and breast examination, we can categorize patient according to the T, N, and M. Okay. Then we can categorize them into early breast cancer, locally advanced, or metastatic. Okay. So during the examination, how to remember? Very easy. So when you palpate the breast and the axilla, okay. So if you palpate the axilla, then you notice the patient has lymph nodes, and the lymph nodes is fixed. Okay. So it means clinical N is N2. So all N2, okay, means any N2 patient, this patient is a locally advanced breast cancer. Okay, very easy. That's number one, N2. Okay, if you palpate the lymph nodes, it is mobile ipsilateral axillary lymph nodes. This is N1. Then you see the size. So if the size is more than 5 centimeters, which is T3, so T3 N1, this is a locally advanced breast cancer. Okay. All T4 patient, whether there is extension to the chest wall, there is involvement of the skin, mix both A and B or D, T4D, all of them are locally advanced breast cancer. Okay. If there is metastasis, automatically this patient is under stage 4, which is metastatic breast cancer. So other than that are early breast cancer. So patient with T1, T2, okay, neither N1 or N0, all are early breast cancer. So the maximum is patient with more than 5 centimeter tumor, but then the N is 0. This is also early breast cancer. That's how you remember. Okay, you find the N2 first. All N2 is locally advanced. If patient has N1, see the size. If the size is T3, more than 5 centimeters, this is locally advanced. All T4 is locally advanced breast cancer. Patient with metastasis is metastatic breast cancer. Other than these two, will go under early breast cancer category. Okay, so that is the clinical approach. Okay, so once you have divide the patient into either early, locally advanced, or metastatic breast cancer, then we can proceed to the next step, and we see whether the patient needs imaging for metastasis. So in early breast cancer, if the patient is asymptomatic, so there is no need for routine imaging screening. Okay. However, if there is symptoms or signs of lung, liver, bone metastasis, or any abnormal lab tests, for example, LFTs, liver function tests, then we can do routine imaging for metastasis. So the least that we can do is a chest X-ray to see for lung metastasis, and ultrasound liver to look for liver metastasis. The best is if you can get CT, thorax, abdomen, and pelvis for staging. Okay. If there is localized bone pain or elevated ALP or symptoms of bone metastasis, we can do bone scan. Okay. If the X-rays or the CT is negative. Okay. Alright. That is for early breast cancer. Okay. For locally advanced or metastatic breast cancer, we suggest to do CT, thorax, abdomen, and pelvis. Okay. Bone scan, MRI, PET CT scan depends on indication. Okay. So after your clinical history and examination, you stage the patient, clinical staging the patient, and you arrange whether the patient needs imaging for metastasis. And at the same time, you arrange for mammogram or ultrasound of the breast and through cut needle biopsy. Okay. Alright. So imaging pathology. Alright. Okay. Once the imaging and the through cut needle biopsy is done, then we see again the patient and we review the imaging and we review the HPE. Then now we divide the patient into the pathological staging, whether the patient is in the early, locally advanced, or metastatic breast cancer. That is our clinical approach every time in the clinic. So we need to upgrade ourselves when we see patient, especially breast cancer patient. Okay, all right. So treatment. So the gold standard is always a multidisciplinary team effort. Okay, So it involves a lot of teams, surgeons, radiologists, pathologists, oncologists, even the breast scanners, the plastic surgeon, and anesthetists. Okay, it involves a lot of team effort, multidisciplinary effort. Okay, so we divide the treatment into early breast cancer, locally advanced breast cancer, and metastatic breast cancer. So we go through one by one. So we go to early breast cancer first. Okay, so this is the algorithm, the management of early breast cancer from our latest Malaysian breast cancer CPG, the third edition. Okay, we will go again to this algorithm later. Okay, all right. So when we talk again about early breast cancer, remember patient with stage 1, stage 2 and stage 2, stage 2A and stage 2B. Okay, so the primary treatment of early breast cancer, the mainstay treatment is surgery. Okay, how to remember? To make it easier, we divide the surgery into two. One is breast, another one is axilla. So we have primary breast surgery, then we have primary axillary surgery. Okay, then post-operatively, we see whether the patient needs adjuvant therapy or not. So adjuvant therapy consists of radiotherapy and systemic therapy. So we'll go one by one. Okay, so we go to the breast first, which is breast surgery. Okay, so when we talk about primary breast surgery in early breast cancer, we have two options. Number one, we have the breast conserving surgery, BCS. Number two, we have option of mastectomy. Okay, so breast conserving surgery. So the aim is to get a good oncological outcome and also a good cosmetic outcome. Okay, oncologically, BCS has similar overall survival and local recurrence as compared to mastectomy. Okay, at the same time, they also preserve a good cosmetic outcome. That is the aim of breast conserving surgery. Okay, however, there is contraindication. Okay, so absolute contraindication is in patient with multicentric disease. Means when you divide patient breast into quadrants, so patient has multiple lumps at multiple quadrants. So this is what we call as multicentricity. Or patient with diffuse malignant microcalcification on mammogram. Okay, or patient in pregnancy except in the third trimester. Why? Because when we do breast conserving surgery, post-operatively, it must be followed by whole breast radiotherapy. So radiotherapy to a pregnant lady is contraindicated. However, if we do the breast conserving surgery at the third trimester, we can give the whole breast radiotherapy post-delivery. Okay, that's why the absolute contraindication is in pregnancy except in the third trimester. So we do the operation in the third trimester, the whole breast radiotherapy post-delivery. Okay, or patient who has persistent positive margin at re-excision. Okay, and lastly, a patient with previous radiotherapy to the chest. Okay, for example, in the treatment of Hodgkin lymphoma. Relative contraindication, patient with connective tissue disease such as scleroderma, patient with multifocal disease, or patient with a large tumor size, more than 20% the tumor breast ratio, or patient with BRCA mutations. Okay. There are also certain category of patient which has a role of neoadjuvant chemotherapy. So we give neoadjuvant chemotherapy for BCS in patient with large tumor size, which is slightly larger than 20% of the tumor breast ratio. So we give the neoadjuvant chemotherapy. So this neoadjuvant chemotherapy can make the size of the tumor small. Okay, hence we can get a good outcome, cosmetic outcome of this breast conserving surgery. Okay, we also give neoadjuvant chemotherapy in patients with triple negative hormone receptors and or patient with HER2 positive only patient, HER2 positive but ER/PR negative. So these two type of patient, triple negative or HER2 positive in early breast cancer, we give neoadjuvant chemotherapy. Okay. However, there is prerequisite before giving neoadjuvant chemotherapy. So we have to tumor tag. So we put clip at the center of the tumor. Why? Because sometimes when we give neoadjuvant chemotherapy, there will be complete pathological response where the tumor completely disappear post chemotherapy. Okay? So if we don't tag the tumor, we don't put the clip, we don't know where to cut. Okay, that's why before we give neoadjuvant chemotherapy, we tag the tumor, we put the clip. Okay, and any patient for sentinel lymph node biopsy, it must be done before this neoadjuvant, because sentinel lymph node biopsy accuracy will fall less than 80% after we do neoadjuvant chemotherapy. Okay, right. So the resection margin for breast conserving surgery, so macroscopically, it's about 1 centimeter from the tumor. Microscopically, is no tumor, no carcinoma, and thick margin. Okay, for non-palpable tumor, normally we will do hook wire localization, and then the specimen we will send intraoperatively. We will send to radiologists to do imaging to see whether we have completely taken out the tumor or not. Okay. So if the margins involved, we will repeat white local excision with intraoperative assessment. Normally, we will do frozen section. Okay, this is on breast conserving surgery. Okay, mastectomy. Okay, indication all those patients who are contraindicated for BCS. Okay, and then patient's decision. We can give option BCS or mastectomy, and then depends on the patient's decision. And we also can do prophylactic bilateral mastectomy in BRCA1, BRCA2 mutation. This reduces breast cancer risk for more than 90%. Okay, mastectomy complication, like we always counsel patient pre-operatively, they can get seroma, wound infection, skin flap necrosis, pain, phantom breast syndrome, arm mobility and shoulder dysfunction, even pneumothorax, and brachial plexopathy, which is stress injury from malpositioning. Okay, so types of mastectomy. So previously, we did a radical mastectomy where we take out breast, most of the skin, pectoralis, major and minor muscle. Then we remove level 1, level 2, and up to level 3 axillary lymph nodes. So this is a radical mastectomy. However, patient has higher mobility and cosmetically is not appropriate for the patient. Hence, we modify. So our current standard is a modified radical mastectomy where we take out breast and a bit of the skin, and then level 1 up to level 2 axillary lymph nodes. So this is a modified radical mastectomy. Okay. There is also technique of skin sparing mastectomy where we spare most of the skin. However, this is contraindicated in inflammatory breast cancer or extensive skin involvement. Okay. Another technique, we have nipple areola sparing mastectomy. But then the tumor must be less than 2 centimeters and then must be more than 1 centimeter from the nipple areola complex. Okay. So all mastectomy can be carried out with or without breast reconstruction. This depends on the expertise of the center and the availability of the treatment in the center. Okay, so this we need to discuss with the patient. Okay, all right. That is on breast surgery. Okay, next is axillary surgery. So for early breast cancer, there are two options. One is sentinel lymph node biopsy. Okay. Number 2 is axillary lymph node dissection. So we'll go one by one. Okay, sentinel lymph node biopsy. So the aim is we want to reduce the complication of axillary lymph node dissection, which are lymph edema, paresthesia, seroma, and motor nerve injury. Okay. However, this sentinel lymph node biopsy is only indicated in these patients. Okay, so the patient must be T1, T2, and 0 patient. T1, T2 clinically negative lymph nodes means negative, not palpable in the physical examination. and also no lymph node is detected in the imaging, in the mammogram or ultrasound. So T1, T2, clinically negative lymph nodes. Okay. Sometimes clinically it's not palpable, but then in the mammogram or ultrasound, it shows there is enlarged lymph nodes. Then we can take FNAC. So if it is radiologically positive with negative FNA, we also can do sentinel lymph node biopsy in this kind of patient. So radiologically positive lymph nodes, but with negative FNA. Okay, so the indication for sentinel lymph node biopsy, patient with T1, T2, clinically negative. Okay. So technique, normally we will do dual method. Number one, we give radioactive colloid a day before. Okay, and then intraoperatively, we will have a probe or apparatus which can detect the hot nodes. Okay, so the hot nodes which carry this radioactive colloid. So we will take out these hot nodes. Okay, and then that is number one. We give 1 day before. Okay, and then intraoperatively, so after intubation, we will inject blue dye into the skin or parenchyma of the breast, either peritumoral or subareolar. Okay, before the skin incision. Okay, then we will massage the breast about 5 to 15 minutes. Okay, to help the blue dye to spread to the sentinel lymph nodes. Okay, then intraoperatively, we can detect which is the sentinel lymph nodes by seeing lymph nodes which has the blue dye uptake. Okay, so how to identify? So intraoperatively, number one, we see any blue nodes, we will remove it. Okay, any hot nodes from the radioactive colloid, we will remove it also. Okay, so these sentinel lymph nodes we will send to the lab, and they will identify either by a frozen section, touch preparation, or hematoxylin eosin staining to see whether it is positive or negative. Okay, all right. So there is two landmark trials for sentinel lymph node biopsy that we must know. Okay, number one is the we call it ZOO11 trial. This is in 2011. Okay, so in this trial, the study is on patient with T1, T2, and 0 patient who underwent BCS, breast conserving surgery. Okay, and then all these patients, when they did intraoperative sentinel lymph node biopsy, they have 1 or 2 positive nodes only, 1 or 2. Okay, and then this group of patients is divided into two. One, they just did the sentinel lymph node biopsy. Okay, and the other group, they proceed with axillary lymph node dissection. So from these two groups, they found out that by doing just the sentinel lymph node biopsy is not inferior in survival or local recurrence compared to doing axillary lymph node dissection. So what we can conclude is, so in patient with T1, T2 tumor, clinically negative, only positive 1 or 2 positive lymph nodes in the sentinel lymph node biopsy. So if the patient plan for BCS, breast conserving surgery, they can avoid axillary lymph node dissection. However, post-operatively, they need to give whole breast radiotherapy. Okay, that is the conclusion from the ZOO11 trial. Okay, another trial is the Amaros trial. This is in 2014. Okay, they study on patient with same thing, T1, T2, and 0 tumor, but then this group of patients underwent either BCS or mastectomy. And so the same, they have 1 or 2 positive lymph nodes on sentinel lymph node biopsy. So this patient, they divide into two groups. One group underwent axillary lymph node dissection. The other group only underwent axillary radiotherapy. So what they see in the study, so axillary lymph node dissection and axillary radiotherapy after a positive sentinel lymph nodes are comparable in axillary control. Same. Okay. However, higher morbidity in axillary lymph node dissection because of the dissection. Okay. So what we can conclude is in patient T1, T2 tumor, clinically negative lymph nodes, okay, preoperatively, then there is only 1 or 2 positive nodes on sentinel lymph node biopsy. If the patient underwent mastectomy, okay, they can choose either one, either axillary lymph node dissection or axillary radiotherapy. Okay, because both are comparable. Okay, however, less morbidity in axillary radiotherapy. Okay, that is the conclusion of Amaro's trial. Okay, so we can conclude is the conclusion of sentinel lymph node biopsy. If intraoperatively the sentinel lymph node is negative, then no need to proceed with axillary lymph node dissection. Okay, if there is 1 or 2 positive sentinel lymph nodes, if the patient underwent breast conserving surgery, so post-operatively enough, we just do post-operative whole breast radiotherapy. Okay, if the patient has 1 or 2 positive sentinel lymph nodes, if the patient underwent mastectomy, they have 2 options, either want to give axillary radiotherapy or axillary lymph node dissection. However, less morbidity if the patient underwent axillary radiotherapy. Okay, so if 3 or more, automatically patient will go axillary lymph node dissection. Okay, this is on sentinel lymph node biopsy. Okay, then axillary lymph node dissection. Okay, the aim is for us so we can stage the disease, the end stage. Then for disease control, so this reduces risk of axillary recurrence if we take at least more than 5 lymph nodes. Okay, so as I said before, typically axillary lymph node dissection we will take out at least 10 lymph nodes because of the N3 pathological N3 is 10 or more. Okay, and then this will help us guide in the adjuvant treatment selection. Okay, so indication radiologically positive lymph nodes on FNA or sentinel lymph node biopsy 3 or more positive. Okay, or any sentinel lymph node biopsy positive in patient has mastectomy, one of the indication. So mastectomy, patient has 2 options for sentinel lymph node biopsy. Okay, then contraindicated in patient with DCIS or node negative early breast cancer. Okay, so the extent of dissection, level 1, how we divide according to the anatomy. So level 1 is lateral to the pectoralis minor, level 2 posterior to the pectoralis minor, and then level 3 is medial to pectoralis minor. So our extent of dissection is up to level 2. Okay, this gives the most benefit and acceptable morbidity and complication rate. Okay, level 3 we will only take out the axillary lymph nodes level 3 if it is clinically palpable. Okay, so the complication, you can see number 1 is limb edema, so up to 30% in axillary lymph node dissection as compared to only 3% in sentinel lymph node biopsy. Then seroma, shoulder dysfunction, loss of medial arm sensation, and also motor nerve injury. Okay, all right. So that's on axillary surgery. Okay, all right. So we will stop now. Then we will continue further in my second part of my lecture. So as we have touched on the early breast cancer part, the breast surgery, and then the axillary surgery. So next will be adjuvant therapy. Okay, so we will stop now, and then I will continue next in the part 2 of my lecture. Thank you.